Hello everyone, my name is Frédéric Michel. I'm from Lausanne in Switzerland. And so before I start, I would like to disclose the fact that I'm today leading a consulting company based in what we call the Swiss Silicon Valley, and where we focus on digital innovations with medical applications. As you know, probably better than me, most patients who test positive for the new coronavirus remain asymptomatic or develop flu-like symptoms. But we know as well that some of them are going to develop complications. And the first and usually most severe complication is obviously the pneumonia that may become an ARDS. And so we know that some of these patients will be admitted in the ICU, will be mechanically ventilated, and actually even some of them will require ECMO. Another complication is acute circulatory failure, and 6 months ago, we knew very little about this complication, most publications focusing logically on pneumonia and ARDS. So 6 months ago, we did an international survey with many colleagues from different countries, where we questioned intensivists about the hemodynamic monitoring and management of COVID-19 patients. And when we ask them about vasopressor support, you can see that the majority of intensivists, and we had feedback from over 1,000 intensivists worldwide, so the majority of them said they were using frequently or very frequently vasopressor support in these patients. We know now that indeed, if we look at large observational studies, that around 2/3 of COVID-19 patients receive continuous vasopressor support in the ICU. So why? Why so many patients need vasopressor support? So there are different possible explanations for acute circulatory failure in this context. First of all, vasodilation, of course, or because of systemic inflammation. It's not specific to the COVID-19 virus. Also, the fact we are using very often sedative drugs in these patients who, as I said already, are most of the time mechanically ventilated when they are in the ICU. Some patients may be hypovolemic as well because of the fever they have or they had, also because of fluid restriction, which is very often the rule when they are admitted at the hospital to try to prevent the development of pulmonary edema and the need for tracheal intubation. But we know now that the new coronavirus can actually affect directly the heart or indirectly. And actually, most of the time, I mean, when we observe, or if you observe left ventricular systolic dysfunction in these patients, it's going to be related to the circulating cytokines. But we know from a few studies that a real myocarditis is actually possible as well. Finally, that would not be surprising to observe some degree of right ventricular dysfunction in these patients as well. First of all, because most of them are mechanically ventilated, very often with high level of PEEP. And also because we know that pulmonary obstruction, pulmonary embolism is more often observed in this subset of patients than in the general ICU population. So when we did the survey 6 months ago, we asked clinicians, I mean, do you do, or do you often do echocardiographic evaluation in these patients? And you see that once again, a majority of intensivists said yes, frequently or very frequently, we perform an echocardiography in these patients. And when we do one, very often actually we observe a hyperkinetic state, but sometimes we observe hypovolemia. Sometimes we also observe left ventricular dysfunction or right ventricular dilation. We know now from prospective studies that indeed cardiac dysfunction is very often observed in these patients. And this is an article published in Circulation, 100 inpatients with COVID-19. And you see that normal echo is actually the exception. This is another very interesting study published in the European Heart Journal. Over 1,200 patients from 69 countries with COVID-19 And you see that once again, it's very common to observe either left or right ventricular dysfunction, or actually sometimes both. What's very interesting as well in this study is that they nicely show that echocardiography changed management is 1/3 of these patients. So it's absolutely key to do an echo evaluation in these patients because, as you understood, there are different mechanisms that may be responsible for hemodynamic instability. And if you want to be sure you choose or you select the right therapy, it's very important to understand what's the main underlying mechanism. Some patients as well will develop acute kidney injury. And this is a very nice meta-analysis recently published in Intensive Care Medicine about AKI in a critically ill patient with COVID-19. So they pooled all studies where the number of acute kidney injury events were collected. And they showed that on average, between 11 to 14% of these patients develop AKI. The mechanism responsible for AKI are actually pretty complex and multiple, but clearly fluid restriction and hemodynamic instability may play a role. By the way, if you look at the guidelines published by NICE in the UK, they clearly acknowledge that acute kidney injury associated with COVID-19 may be caused by volume depletion. So fluid therapy is a real challenge in these patients because, of course, on one hand, the temptation is to fluid restrict, to decrease pulmonary edema, to decrease intrapulmonary shunt, and to improve arterial oxygenation. But on the other hand, if we restrict too much, cardiac output will drop, which may increase acute kidney injury, decrease SVO2, and because of the intrapulmonary shunt, actually decrease or contribute to decrease SaO2. So the temptation may be to give them fluid to optimize cardiac output, optimize kidney perfusion, decrease acute kidney injury. On the other hand, we know we may increase pulmonary edema, increase intrapulmonary shunt, and decrease arterial oxygen saturation. So what can be done? We need to be very rational. We need to predict fluid responsiveness. We know that predicting fluid responsiveness is useful to identify patients who may benefit from fluid administration. But maybe more importantly, it's also useful to identify non-responder patients and then prevent unjustified fluid administration in these patients. So predicting fluid responsiveness is clearly a way to individualize fluid management. We know already in surgical patients that when anesthesiologists are predicting fluid responsiveness to individualize fluid therapy, it is associated with a dramatic improvement in post-operative outcome. But until recently, we did not have any evidence for medical patients, particularly for septic patients. So I can actually today share two recent studies with you. They were published this year. And this is the first one published in Annals of Intensive Care. It comes from Argentina. It's a large multi-center prospective cohort study done in patients with sepsis or septic shock. And what they showed is that when clinicians predict fluid responsiveness, it's actually an independent predictor of survival. And there is another study that was recently published in Chest. This is about the fluid response evaluation in sepsis, hypertension, and shock. And once again, they showed that when clinicians were predicting fluid responsiveness, it was associated with a decrease in complications, and particularly a decrease for renal replacement therapy. In the survey, when we asked clinicians, do you predict fluid responsiveness, we were actually surprised that most of them, a vast majority, 84%, said, yes, we do. We were surprised because we had in mind this large study published 5 years ago, done 7 years ago, but published 5 years ago by the European Society of Intensive Care Medicine, showing that the administration of fluid was arbitrary in most critically ill patients, that clinicians obviously had not adopted at that time the concept of fluid responsiveness. So now things have changed. Most clinicians predict fluid responsiveness in COVID-19 ICU patients. And when we ask them, how do you predict fluid responsiveness? Most of them said, we use echo, or we use PPV, or we do passive leg raise maneuver. So this slide is a good transition to discuss now the practical aspect, and I suspect that's what you are actually really interested in. So first of all, regarding echocardiography, you can simply do a qualitative evaluation. There are studies, particularly from the group of Antoine Viard-Baron, showing that it's probably sufficient, at least for a basic evaluation in the ICU. And so this is an example of a basic transthoracic evaluation. You will look at the left ventricle, at the right ventricle size. You will look at the IVC and the IVC variation with mechanical ventilation. If you use TE, you will get basically the same information, but instead of looking at the inferior vena cava, you will look at the superior vena cava. What's very convenient today is that actually to do an echo evaluation, you don't need anymore to bring the big machine at the bedside. You possibly have a probe in your pocket you can connect to a tablet or to a smartphone. So these tools are very useful for qualitative evaluation. Of course, if you want to quantify variables, you will need to use a high-end machine. And some of them are actually now pretty smart. I mean, they have smart software helping you to measure the VTI, the aortic VTI, or the IVC variation induced by mechanical ventilation. So these are just a few examples of what's available today on the market. There are possibly more, but I just selected 2 examples here of semi-automatic VTI measurement software. It does exist as well for the semi-automatic IVC variation quantification. So it's clearly becoming easier to do echocardiographic evaluation, and in particular to predict fluid responsiveness with echo, and that's probably why so many respondents to our survey said that what they use in priority to predict fluid responsiveness. But if you want to predict fluid responsiveness without using echo, it's possible. I mean, as you know, there are actually many different tests or methods which have been described and validated. The first one is simply to look at the respiratory swings in the blood pressure waveform on the bedside monitor. It could be also a stroke volume variation from a cardiac output monitor if you are using one. And of course, what's very convenient with PPV and SVV is that you just need to look at the number to predict fluid responsiveness. You don't need any intervention. But, as you know, there are many limitations to the use of PPV and SVV that were summarized by these mnemonic limits in this paper I published with Denis Chemelin and Jean-Louis Teboul a few years ago. And one of the main limitations is, of course, mechanical ventilation with a low tidal volume. Protective mechanical ventilation you are obviously using in COVID-19 patients. So how can you predict fluid responsiveness in this context? You can do a passive leg raise maneuver. It's going to mimic the effect of a fluid challenge. You're going to mobilize the blood from the legs to the abdomen and the thorax. And then if you observe a significant rise in cardiac output during the passive leg raise maneuver, you can predict that if you give fluid, you will also observe a significant increase in cardiac output. The big advantage of this passive leg raise maneuver is that you don't need to give a single drop of fluid. And of course, you are really concerned by excessive fluid administration in a patient with ARDS. Another way to predict fluid responsiveness in this context of protective mechanical ventilation is the tidal volume challenge. So what does it mean? It means, let's say you are using 6 ml per kilogram. So you're going to increase your tidal volume from 6 to 8 just for a few minutes and observe what's happening. Observe the impact on pulse pressure variation or stroke volume variation. If you observe a significant increase in PPV during the tidal volume challenge by more than 3.5%. So for example, if PPV increases from 10% to 14%, you know your patient is fluid responsive, or at least you can predict with a very high sensitivity and specificity that your patient is fluid responsive. Another way to predict fluid responsiveness is to observe or to assess the hemodynamic impact of a lung recruitment maneuver. As you know, they are frequently used to open the lungs and to improve arterial oxygen saturation in IRDS patients. And so we can also use the information coming from hemodynamic monitors if at the same time you track changes in stroke volume. And so in this very nice study from Mathieu Biet, published in Anesthesiology a few years ago, they quantified the effect of a lung recruitment maneuver on stroke volume. And they described two different patterns. In some patients, you will observe a dramatic decrease in stroke volume during the maneuver, whereas in other patients, you observe a slight or no change in stroke volume. And Mathieu showed in that paper that if you experience a dramatic decrease in stroke volume during the maneuver, you can predict your patient is fluid responder. And the best cutoff value to discriminate between responders and non-responders in this study was 30%, a 30% decrease in stroke volume during the recruitment maneuver. So let me show you an example. This is a patient with a slight decrease in stroke volume. You see the stroke volume index is recorded in blue, and in green you have the peak airway pressure. So you see very well the lung recruitment maneuver when the airway pressure was increased up to 30 centimeters of water for 30 seconds. And you see a slight decrease in stroke volume by less than 30%. And you see as well that during volume expansion, actually, stroke volume didn't change. So this patient was indeed not fluid responder. Here you have a different patient. And during the recruitment maneuver, you see a dramatic decrease in stroke volume by more than 30%. And you can see as well that when these patients receive fluid, the clinicians observed a significant decrease, a progressive but significant increase in stroke volume. So this patient was obviously fluid responder. Another way to predict fluid responsiveness is to do an end expiratory occlusion test where you're going to stop mechanical ventilation for about a minute, 30 seconds, up to 1 minute at end expiration. And if you observe a significant improvement in hemodynamics during this end expiratory pause, you can bet that if you give fluid, your patient will respond as well by a significant improvement in hemodynamics, for instance, stroke volume and cardiac output. Last but not least, you can do a fluid challenge or a mini fluid challenge and administer 100 or 200 ml of fluid quickly and assess the impact on hemodynamic variables. But of course, the fluid is given, and so it's always better to be able to predict the response before giving any drop of fluid. SVO2 measurements. SVO2 measurements might be useful as well, and not at all because of the Manu River study. No, just because it makes sense. Because when you apply PEEP, you try to recruit the lungs and improve arterial oxygen saturation, and then your goal is to improve oxygen delivery. But if at the same time you decrease venous return, cardiac output, you may actually decrease oxygen delivery. So finding the right balance or the best compromise is easy actually if you monitor SVO2 or if you measure SVO2 during a PEEP trial. Indeed, the best PEEP, at least from a hemodynamic standpoint, will be the one associated with the highest SVO2 value. In the survey, when we question intensivists about the use of SVO2, I was a bit surprised as well, because many of them are measuring SVO2. But when they measure SVO2, they don't use a SWAN, they don't use a fiber optic system, they actually do a sample, a blood sample from the CBC. And I think it's a very reasonable attitude. Transpulmonary arterial modulation is also a technique you may want to use in these patients. It makes a lot of sense because we know it gives both hemodynamic information, but also information about the lungs. You have extravascular lung water, you have the pulmonary vascular permeability index. But remember, I said echo is today widely used, and you can also look at the lungs, you can quantify B lines, and there are even smart software which have been developed for this semi-automatic quantification of B lines. So you have a way, a non-invasive way actually to quantify or estimate pulmonary edema in these patients. On the top of that, if you look at the lungs, you will be able to visualize a lung consolidation. You will be able to identify and quantify pleural effusion. So once again, echo is extremely useful to gather information, not only about the heart, but also about the lungs. And clearly, when you will look at the heart, you will look at the lungs during the same evaluation. That's probably the reason why in the survey, when we ask clinicians, how do you assess and quantify pulmonary edema? Most of them said we use mainly echography, and you see that only 20% were actually using transpulmonary thermodilation. And once again, this is a feedback from over 1,000 intensivists from all over the world. So in conclusion, I would say that many COVID-19 ICU patients develop acute circulatory failure. Echocardiography is indispensable. You understood why, because there are different explanations, different mechanisms responsible for hemodynamic instability, and it's very important to identify what is responsible for shock in order to offer the best treatment to our patients. The prediction of fluid responsiveness may improve outcome, at least in patients with septic shock. There is no study done specifically in COVID-19 patients, but we may reasonably believe this is, of course, the same. And it's actually part of current guidelines. If you still have skepticism regarding the need to predict fluid responsiveness, be aware that the Asian Critical Care Clinical Trials Group published this paper in the Lancet Respiratory Medicine, and as you can see, said, check preload responsiveness. These are the surviving sepsis campaign guidelines that have been updated for COVID-19, and they clearly say dynamic parameters should be used to assess fluid responsiveness. And last but not least, you have also recommendations from the WHO, and they clearly state that you should consider dynamic indices of volume responsiveness to guide fluid administration. With that, I thank you very much for your attention.